Safeguarding is everybody's business, but in primary care it's a little bit more our business than anybody else's. Health Inspector at Wales note there's currently no support or specific training for GP safeguarding leads to enable them to perform this role. They suggest that general practice would benefit from increased peer support in safeguarding, and our group meets both of these recommendations. The overarching aim of my group is to raise the standard of primary care safeguarding to that of those practising at the very highest level. The idea is underpinned by the 4 principles of prudent healthcare, focusing on doing only what is needed, caring for those with the greatest health needs first, and reducing inappropriate variation. With this group, we're all the experts, and we've found that if you get 10 people in a room discussing a really complicated case, you'll get 10 subtly different suggestions about how to manage that case. This makes for a really interesting debate and increases our knowledge base, and after 12 months of regular meetings, we can demonstrate that it also improves care and patient outcomes. So, the aims of the group are to focus safeguarding on local issues and share best practice. Examples I've got are practices reviewing children who aren't brought for same-day appointments, because that's a recognised marker for vulnerability. The most important and valued aspect of our meetings is that we discuss interesting or challenging cases in a supportive and confidential setting. Our group is not for the clear-cut cases. We all know what to do with obvious cases of sexual or physical abuse. We've got our laminated pages of protocols to follow for that. Our group's for the more ambiguous shades of grey cases. You walk a tightrope between referring inappropriately and placing an already struggling family under further stress, or not referring and leaving a vulnerable adult or child at risk of further harm. So if you discuss a case confidentially with 9 other safeguarding leads who all agree and share your concern and feel that a referral is appropriate, that gives your decision credibility and gives the clinician support and confidence. The meetings are multidisciplinary. The core members are the safeguarding leads, but other doctors with an interesting case to present are always welcome, as are medical students and trainee GPs, who often bring a really interesting take on cases. By sharing best practice in this way, we aim to facilitate all practices increasing their safeguarding activities to those practising at the highest level. Why does all of this matter? The evidence that demonstrates the potentially lifelong damaging effect of adverse childhood experiences is clear and compelling. We know that the emotional and economic impact of domestic abuse profoundly limits the ability of affected individuals to reach their full potential. We have the opportunity to address this more effectively.